Good afternoon, all of you. Thank you so much, the President and the Council of Anuradhapura Medical Association for inviting me. This is Cristiano Ronaldo. It's not no more a stranger for all of you. Well, he has been having shortness of breath for some time, for about a year or so, and has been evaluated by many experts and facilities to find out the cause, but most of them have failed. Lately, after about 2-3 years, he's been finally diagnosed as having a form of cardiac arrhythmia, where he had to undergo a laser ablation of his conducting system. So this was revealed by his mom recently, actually. This has happened in the age of 15, not now, of course. So this shows us how difficult it would be to analyze, evaluate shortness of breath. It's quite difficult. With that, ladies and gentlemen, may I begin evaluation of shortness of breath, pearls for primary care and beyond. Right, this is the outline of my talk. The magnitude of problem, I mean, it's a very, very common presentation to us in A&E, ETUs. I'm pretty sure it will be the same for the primary care physicians in their general practices also. In fact, it's the second most commonest presentation to us in Goal last year. So why do we get shortness of breath? Well, it's either the increase of the rate or the depth of respiration. That is because of say attempt to extract more oxygen from air, or either to push more carbon dioxide or hydrogen from your system out. As you know, we have oxygen, carbon dioxide, hydrogen sensors called chemoreceptors located peripherally and centrally. And of course, we have a set of mechanoreceptors located in the respiratory pump, in the walls and the bronchioles also. So from the information that the brain gets from the receptors, it makes changes of the depth and rate. So what we need to understand here is that shortness of breath is a symptom of deranged physiology. That is so much important to understand. It's not something about the pathology, it's the physiology. So that's really, really important. So these are clinical measurements that you could do to assess the respiratory physiology, that is respiratory rate, depth, and saturation is a very common measurement, and work of breathing. You can have normal saturation, 100, but with very high work of breathing. In that case, also the physiology is deranged. This is how you assess work of breathing. Use the rate. Well, respiratory rate, I must say, one of the most neglected clinical parameter. Very rarely it's been assessed, but which is the one which gives you a thundering amount of information as well about the patient's physiology. And of course, you need to use the usage of accessory muscle. You give a score out of 7. If it's more than 3, your physiology is deranged. Why are we so much bothered about the physiology? Well, physiology keeps us alive, isn't it? The permanent cessation of brain function is dead. So the moment you stop your physiology, you are called dead. So deranged physiology drives us towards cardiorespiratory arrest and death, and which is a very rapid process also. It doesn't take years. It's like you are traveling in a highway. You know how fast you travel, don't you? And deranged physiology takes you through hypoperfusion, multi-organ failure, cardiorespiratory arrest to death. Very quick time unless you do something. Right, evaluation of shortness of breath essentially and ironically should start from physiological stabilization. Otherwise, you wouldn't have a patient to evaluate. So what do? You need to use this golden tool ABCDE. By doing so, you bring the physiology back. And of course, you can have some pathology towards why during ABCD assessment. And that's the time you start evaluating the pathology from our well-known golden tool, history, examination, and investigations. Just look at this video.
Inhalation allows oxygen to enter the body pulling air into the nose and mouth, lungs, and into the air sacs, called alveoli, where gas exchange takes place. Alveoli move freely when air is inhaled and exhaled. Capillaries are small blood vessels that line the walls of the alveoli. During gas exchange, oxygen enters and carbon dioxide exits the bloodstream via the alveolo-capillary membrane. Once oxygen molecules move from the alveoli into the capillaries, they dissolve into the plasma and enter the red blood cell called hemoglobin. Hemoglobin contains 4 subunits, each capable of binding 1 molecule of oxygen. Subunits. The other sites bind oxygen more readily. Dissolved and bound oxygen flows through the arterial bloodstream.
So that's how the oxygen molecule in the atmosphere is taken towards the cell in your organ. So it has to pass through many steps, isn't it? So if you have any pathology at any of those levels, would cause hypoxia, and in terms it can cause shortness of breath. It could be problem in the upper airway, lower airway, alveolar membrane, the vessel. If you don't have oxygen to take up, hemoglobin to take up oxygen, you would have the same problem. If not for anything, the hydrogen also could cause the same issue. Right, I will try to go through all these through some patient stories. The first patient, 65-year-old gentleman, Mr. Premadasa, coming with a respiratory rate of 40 and saturation of 90. Can I invite you to join this quiz by scanning this QR code? Right, you can join with each question, don't worry. So we'll go to the quiz. So is the physiology stable? Yes or no? Very good. Majority believes the physiology is unstable. Yes, rightly so, hypoxic and tachypneic, isn't it? So what is the immediate action to save this patient? Find the pathology and treat, or correct the physiology. Just as you see this patient. Very good. 86% believe that you need to correct the physiology, otherwise there's no patient for you to evaluate, isn't it? So we applied ABCD on this patient. The airway was patent, and his trachea was central, bilateral resonance, and he has bilateral fine crepitations. Oxygen has been started, so saturation went up a little. So his physiology is stabilizing now. Okay? Now, have you got any clue towards the pathology also by doing ABCD? So that is the next question. Any clue as to why he is having SOB? Pathology at a lower airway level or at the alveolar membrane? Please answer. Very good. It's at the alveolar membrane level. No? The clue was the crepitations. Crepitation denotes a pathology at alveolar level. So that's how you need to process this. These are the possible pathologies. It could be fluid, inflammatory exudate, fibrous tissue, blood. Anything could prevent your oxygen getting to the vessels. Now, we have a clue about the pathology, so it's time for us to assess the pathology properly. How? History, examination, investigation. He's a diabetic person coming with shortness of breath, very sudden, acute onset, and has orthopnea also. What is the pathology which could suddenly arise at the alveolar level of both lungs? Fluid, inflammatory material, fibrous tissue. Yeah, it has to be fluid, isn't it? When the venous pressure goes up, your fluid can extravasate into the alveolar membrane, blocking oxygen coming to the vessel, so you become hypoxic and short of breath. Examination reveal elevated JVP. This is the auscultation of his heart. Just listen. The question is, what can you hear? Is it normal rhythm or S3 gallop? Very good. 95% believe it's S3. It is S3 gallop, third heart sound. Now, patient has acute pulmonary edema. What is the cause? Is it cardiogenic acute pulmonary edema due to LVF or non-cardiogenic? Please answer. Having S3 on board. Yes, so patient has LVF, isn't it? Why? Because S3 predicts LVF very positively. Positive predictive value of third heart sounds denote LVF is very high. Now, being clinicians, we need to know these positive predictive values, likelihood ratios. Bring your examination findings to the pathology. So that's how you make your decisions clearly. Next question. Now, patients has APU and LVF both. What is the most likely reason for acute LVF? Is it acute coronary syndrome or myocarditis? Yes, it is acute coronary syndrome, which is the one which comes very suddenly. Myocarditis would take days, isn't it? We did a ECG. Have a look. What is shown? STEMI, non-STEMI. Yeah, it is STEMI. Actually, it's anterolateral STEMI. Now, the reason for shortness of breath is acute pulmonary edema due to LVF, due to acute anterior STEMI, due to diabetes. There has to be a reason for everything, isn't it? This is the focus of heart showing LVF and poor ejection fraction, and the lungs showing bilateral B lines. Those are the fluid in the lungs. So the complete diagnosis is this. Actually, diagnosis should have 5 elements in it. Anatomy has to be there, pathology, complications has to be there, and then etiology and the temporal nature, which is called acute, subacute or chronic. So this is what you need called a complete evaluation of a patient. You need to have all these 5 elements fulfilled for you to have a complete diagnosis. So crepitations can come from the lungs primarily, or it could be a disease in the heart. So lungs, it is gradual onset most of the time, maybe unilateral or bilateral. There's no much of paroxysmal nocturnal dyspnea. The reasons being infection or fibrosis. When it comes to heart, it's very sudden onset and always bilateral and have PND, and there are cardiac signs to support your decision. Maybe S3 as this case, loudest one, murmurs, rubs, lot of things. And the reasons are being shown. The pearl is, ladies and gentlemen, use clinical signs and symptoms for evaluation. Well, you need to search for them. It's not something patient come and say. You need to dig the history to find gems and try to explain all these from your history and examination. I would like to bring another very important, very soft pearl for you to have a very good rapport. If you have a very good rapport with the patient, it will be really, really easy to get all these clues. So welcome them with a smile. Coming to the second story, Jane coming with these numbers, physiology abnormal. What do you do? A, B, C, D. She cannot speak, producing just sound. Trachea central, resonant, no creps. Oxygen started, saturation went up a little. This is Jane. Right. What can you hear? A stridor or wheeze? Yes, that is a stridor. How do you differentiate stridor from a wheeze? Stridor is an inspiratory high-pitched sound, whereas wheeze is an expiratory high-pitched sound. Any clue why the patient is having SOB now? Pathology at lower airway or upper airway? Yes, it's upper airway. That is what stridor is. When the extrathoracic upper airway has any problem, you can have stridor. So history, she is a diabetic on insulin, having evidence of a infection actually. So it's a Ludwig angina causing upper airway obstruction. Sometimes you may not see these infection features externally. You may have to open up the mouth and see the inflamed tissues. The pearl is, stridor is a sign of upper airway obstruction. Listening and perception save lives. You need to listen carefully. Use your eyes, use your touch, ears, everything when you encounter the patient so that you can extract the clues and signs. Stridor can be acute or subacute. Another soft pearl is consider your patients as fellow human beings so that you can extract most of those signs. Third story, 32 years Pradeep, coming with SOB, these size numbers, physiology unstable. We did ABCD, airway was patent. His right side was expanding lesser and trachea to left and all those signs were there. Oxygen started. Any clue why the patient having SOB? Pathology at alveolar level, upper airway level or right lung itself? Yes, it's a pathology in the right lung, isn't it? Sudden onset SOB and chest pain. Pain increases with pleuritic type pain. What is the reason for SOB? Very easy question, isn't it? Yeah, it's a pneumothorax. Pleural effusion would give you stony dullness, isn't it? This is the X-ray to show the tension pneumothorax. So the reason was that, and causes were smoking and Marfan syndrome. The moment you see the patient, don't just go nearby him. Just be quite apart and examine and inspect the other features. There are features of Marfan's in this patient. The pearl is palpating trachea saves lives. It must in an evaluation of SOB. And side with less expansion always carries a pathology. That's one of the golden rule in respiratory medicine. And general inspection helps a lot. And tracheal deviation can have many reasons. And this is another very important soft pearl. You need to bring empathy. That is, to understand patients' problems, things that which are not told. If you have empathy, you can detect more and more and evaluate patients better. Fourth story, 25-year-old lady coming with SOB. These are the numbers. Physiology unstable. So the ABCD done. Trachea central, resonant, clear lungs. Oxygen went up marginally, 92. Any clue why the patient is having SOB? Pathology at airway, alveolar membrane or pulmonary vessels? Yes, the pathology is at pulmonary vessels. No? She hasn't had any Krebs or bronchi, so it could be something beyond the alveoli. Think about the vessel. History, sudden onset, episodic, she has been using OCP, oral contraceptive pills. Examination, loud P2. What is the reason? Pulmonary embolism or pneumonia? Yeah, it's pulmonary embolism, isn't it? So this is the focus to show dilated right ventricle and hyperkinetic apex, and you can see the thrombus in the pulmonary trunk in CTPA. The reason was acute pulmonary embolism due to OCP, and she was thrombolized. The pearl is pattern recognition is very, very important in clinical medicine. And acute SOB, low saturation, clear lungs in a lady. Just think P in the first case. So risk factors, especially when there are risk factors like immobilization, OCP, pregnancy, that is very important. And bring compassion into your practice so that you can evaluate patients and do something to help them as well. It's very, very important. Last story, 45 years old Pereira coming with SOB, saturation 100, respiratory rate 30. What do you think about the work of breathing? It's very high, isn't it? But looks like the numbers are okay, but still, if the work of breathing is high, take it as abnormal physiology. ABCD done, trachea central, resonant, clear lungs, no abnormal signs at all, oxygen started. Sorry. Any clue why the patient having SOB? The pathology is that upper airway, lower airway, alveolar membrane, pulmonary vessels, or somewhere else? What do you think? Oh yes, 95% believe it's somewhere else. Very good. So this is Pereira. What is the pattern of breathing? For small breathing, high stroke breathing. Very good. That is small breathing, no? Good. So what is the reason for SOB? Is it hypoxia or hydrogen ions? Hydrogen ions. Very good. Lanka scored the first place. Congratulations, Lanka. This is the gas. We had that doubt. So pH was low, bicarbonate was low, and patient was on insulin, having gradual onset SOB kind of. So the RBS was 550 and urine ketones positive. The diagnosis was DKA and he has to be treated on for DKA. The pearl is that acute SOB with normal saturation and no lung signs. Acute SOB, normal saturation, no lung signs. Think about acidosis. Don't send them home saying, no, you don't have any issue. Or it could be hypoventilation or anxiety, sorry. And do EBG, ABG, so that's what you can see. Small breathing indicates acidosis. Chronic SOB with normal saturation could be due to anemia, early LVF, some problems can be there. Or like in the Cristiano's case, it could be coming and going paroxysmal arrhythmia. If you do all those things, I believe you can enjoy as a team. That's another pearl that we need to keep in our mind. So coming to the pearls and the take-home message, shortness of breath is a symptom to show that the physiology is deranged, that we need to keep in our mind and try our level best to stabilize them. And then you can assess the pathology. Multiple pathologies can cause shortness of breath. Sometimes very, very difficult to find them out unless you have very thorough and systemic evaluation. You need to use symptom signs, search for them. It's not what they say. It's your duty to search and dig them out. And use history, general inspection, listening, palpation, percussion, auscultation, all your five senses in this regard and analyze in your brain. Use pattern recognition, very, very important. And focus, ECG, chest X-ray, the investigation can help. But don't solely rely on them. Trust your clinical intuition and then plan your investigations. So proper evaluation means finding all these five elements. So likewise, Cristiano's case has been found by some people at least after 2-3 years. If you do all these things, plus apply humaneness, empathy, compassion, I'm pretty sure you're gonna save millions of lives. Thank you so much, all my patients, all of you, Kamal, President, Prasant and Hemal for inviting me. And this is a book that we published recently by our college, internal medicine. You have chapters on each and every acute symptom. This is a SOB chapter where it shows pearls and charts and everything. Thank you so much. I must congratulate the organizers for a wonderful session. Thank you.